Hello. So this is a case of 70-year-old female with history of voice change and neck pain since 6 months. So we'll start with the normal CT anatomy. As you can see, this is a contrast axial image CT neck. So as we scroll, first we'll locate the epiglottis. You can see this leaflet-like structure, transverse leaflet-like structure. This is epiglottis, right? So the midline linear structure above it is median glossoepiglottic fold. So why we call it glossoepiglottic? Because it interconnects the glottis, that is the base of tongue, and this epiglottis. So as it say, glossoepiglottic fold. This is very important structure. Second, this fat-like density. It's the it's the paraglottic fat. Very important. Paraglottic fat. This should be exactly hypodense on CT. And we have to evaluate this area because there's a contraindication to surgery if this part is involved in supraglottic masses. So again, this is first scroll, this is epiglottis. Then this is in the supraglottic part, this is the paraglottic area, paraglottic fat. It is made of fat and lymphatics, so that's why it's a paraglottic space. Now we scroll down. This is a normal side, left side, and this is the abnormal one. So this is aryepiglottic fold, which is a part of false vocal cord, aryepiglottic fold. And the area lateral to it and posterior is the pyriform sinus, normal. Okay, again, this is larynx, this aryepiglottic fold, and this one is the pyriform sinus. Now the abnormal side, on right side, you can see there is an asymmetrical, heterogeneously enhancing mass lesion in the right aryepiglottic fold with involvement of the pyriform sinus. So overall, this is supraglottic mass. Supraglottic area covers again first epiglottis, aryepiglottic fold, and third is the pyriform sinus. Now we scroll down. As you can see, this is thyroid cartilage, normal, true vocal cords, normal. True vocal cord is made of thyroarytenoid membrane. So this is intact. You can see the symmetrical nature, well-defined V-shape, thyroid cartilage, and underneath there is a true vocal cords. So overall, the findings are this is heterogeneously enhancing, irregular polypoidal thickening of mass. It's with epicenter in the right aryepiglottic fold with involvement of the pyriform sinus. It is neoplastic etiology. On histopath, it came out to be squamous cell carcinoma. Now, the next important point is we have to evaluate the nodal metastasis. Again, every supraglottic mass is transferred to the adjacent jugular lymph nodes. Why? Because it has rich lymphatics. And contrary to it, when there is mass in the true vocal cord, it hardly spreads to the jugular lymph nodes. Why? Because true vocal cords do not have any lymphatics. So this is a weird kind of lymph node. You can see, you cannot appreciate the nodal margins here. Looks very ill defined. And on the right, this is almost normal subcentrimetric lymph nodes. But on the left, neither we can appreciate the muscle nor we can appreciate any proper lymph nodal size. So what it is the extra capsular spread of lymph node. As you can see again, indistinct nodal margins and infiltration into the fat. See, this is normal sternocleidomastoid, and here you can hardly evaluate any muscle. So there is involvement of the sternocleidomastoid muscles. So this is extra capsular spread. What are the DDs of the lymph nodes, necrotic lymph nodes with extra capsular spread? First, this is the case, SCC of the supraglottic squamous cell carcinoma, and second is lymphoma Mets. Okay, thank you.